Good morning, and thank you very much, Mohammed, for that super interesting introduction. I'm going to walk you through some slides about how to manage patients with relapsed refractory myeloma, and hopefully you'll get some of the answers to the questions that Mohammed just went through. So let's just kick off with some recommendations on how to treat patients with multiple myeloma. What I'm showing here is a recent paper from Vincent Rajkumar. And the reason for showing this rather than the EHA ESMO guidelines is that the guidelines currently are out of date, and that's a testament to how rapidly the field of multiple myeloma is evolving. And Vincent, as many of you will know, is an authority in the field of multiple myeloma, and I think gives one of the most sensible pieces of advice from many of the experts. So just let me walk you through some of the options that he's discussing. So for younger patients who are transplant eligible, you should manage patients differently according to their genetic risk, which is typically standard versus high-risk patients. Those standard risk patients can either receive a stem cell transplant followed by LEN maintenance, or particularly in the US situation, can have a deferred transplant pathway. Whereas the higher risk patients should certainly get the stem cell transplants and go on to maintenance. What you're seeing here is that for the high-risk patients, we're recommending combination maintenance strategies. And of course, all of these patients should receive a quadruplet induction strategy. For those older patients on the right-hand side, we need to think about not only genetic risk, but also about their frailty, because in often cases, frailty is particularly more important than genetic risk. Daratumumab, lenalidomide and dexamethasone is the cornerstone for treatment of transplant-ineligible patients. But of course, for those frailer patients, you may want to consider a doublet, and you may want to consider stopping treatment earlier. And then for those fitter patients, we've seen some really interesting data about the quadruplet with the CD38 proteasome inhibitor. So DARA VRD and ISA VRD has got some very interesting data, and you can think about that, particularly for those higher risk patients and those fitter patients. And then at relapse, then we can divide your patients according to whether they're refractory to lenalidomide or not refractory. So if you're not refractory to lenalidomide, then DRD or another type of lenalidomide-based regimen, depending on your CD38 refractoriness, is recommended. But nowadays, we are experiencing high levels of lenalidomide refractoriness due to the continuous use of this agent. And then you have to work out whether you are, in addition, CD38 refractory or not. Now, if you're not, then clearly regimens such as ISA-KD or DARA-KD are very attractive. But if you're refractory to a CD38 and a lenalidomide combination, then actually it becomes very difficult. And we're currently looking at selinexor or carfilzomib types of combinations, many of which are unlicensed. So when you're seeing a patient in clinic, you need to think about a number of different factors, and I've shown some of these on the slide, and you need to pull some of these disease-related, treatment-related and patient-related factors together when thinking about how to go through. But clearly what we're demonstrating is that there is a need for additional therapies for those patients who are exposed to your standard therapies. And we've been investigating and learning lots about a number of different types of immune therapies. Fortunately, we have different targets available and different modalities of action available. Most of the work are looking at BCMA-targeted therapies, but we also have treatments targeting GPRC5D, FcRH5 as well. Not only do we have bispecific antibodies, we also have BCMA-targeted antibody-drug conjugates, and we also have CAR T-cell therapies. And many of the treatments that you're seeing on the slide behind me are licensed. If they're not licensed, they are under evaluation, and we hope will be licensed soon. Now, this is a fairly busy slide, but talks about the licensed products that we have to date. We have 2 CAR T-cell therapies targeting BCMA, ide-cel and cilta-cel. We have 2 BCMA-targeted bispecific antibodies, teclistamab and elranatamab, and we have a GPRC5D targeted bispecific antibody, talquetamab. And really what this slide is about is trying to give you an overview or a flavour of these drugs. These have all received approval based on treatments or clinical trials that were performed in highly relapsed and refractory patients. You can see that the median lines of therapy is between 5 and 6, and you can see the high levels of triple-class refractoriness, which is shown here, which is ranging from about 70 up until 97% of triple-class refractoriness. So this really is a heavily pre-treated population. Overall, you can see the median progression-free survivals tends to be somewhere in the region of 12 to 18 months, with a striking difference seen with cilta-cel, which is 35 months. And then when you come to the overall survival, we're seeing, again, reasonable overall survivals of about 2 years. Again, cilta-cel is the one exception to this. Now, that is in the multiply relapsed situation, but clearly there is a rationale for bringing this earlier lines of therapy. We know that your immune system is more competent, we have fitter T cells, that the tumour cells can therefore are seen as being more immunogenic, and your patients are less frail, and you can better give more intensive therapies. There is a high attrition rate as patients go through different lines of therapy. You can see 95% of people receiving first-line therapy. When you get to fourth line, only 15% of patients are receiving that. So you can expose more patients to treatment if you move earlier lines of therapy. And then we're all after curing multiple myeloma, and really it's very difficult to do that at fourth line and beyond. And if we're going to do that, it's earlier lines of therapy. So BCMA is a very important target. It stands for B-cell maturation antigen and sits on the surface of the myeloma cell and is an important receptor that leads to transcription factor upregulation through NF-kappa B, which improves cell survival and proliferation. The natural ligands are APRIL and BAFF, and BCMA is regulated by an enzyme known as gamma secretase, which leads to the snipping of the BCMA antigen into the serum, and you can actually detect this in soluble BCMA. There is evidence that BCMA-targeted therapies work earlier in lines of therapy, and we've seen that through the KarMMa-3 and the CARTITUDE-4 studies, which were phase 3 randomized studies looking at these BCMA CAR T-cell therapies for patients either at 1 to 3 prior lines of therapy in CARTITUDE-4 or 2 to 4 prior lines of therapy in KarMMa-3. And essentially what we're seeing is this significant uplift in hazard ratio. You're seeing a hazard ratio of 0.26 to 0.49 compared to standard of care, showing these significant improvements in progression-free survival for both ide-cel and cilta-cel compared to standard therapy. So we can see that clearly there is better outcomes when you move this up. The major problem is shown below, and we did a survey known as GLAM-1. We presented this at ASH last year, showing the major problems in terms of access to CAR T-cell therapy, and you can see that as being a major problem. So there are a number of clinical trials which are now investigating BCMA-directed therapies in early lines of therapy. You can see at the top for ide-cel, cilta-cel, the CAR T-cells, the bispecific antibodies, and then on the right, the antibody-drug conjugate belantamab mafodotin. And there's a number of different trials for both newly diagnosed at the top and the relapse studies at the bottom. Some of these have actually been reported, so DREAM7 and DREAM8, Martin Kaiser will run through the results, and a number of the other ones are currently under evaluation, and we're really looking forward to understand how these drugs are being seen, both in terms of the efficacy, but in terms of the tolerability profile earlier on. And so with that, I'd like to conclude, and hopefully I've demonstrated to you that the number of treatment options for early relapse disease is increasing, particularly with the advent and the introduction of novel immunotherapies. These treatments have been licensed and approved in the multiply relapse setting and are now being evaluated, and indeed some are now licensed earlier on. But one of the challenges clearly is that once you start using these treatments earlier on, how do we sequence these therapies, particularly when we have multiple BCMA-targeted therapies, and we're going to discuss this in the panel discussion coming through. We know that these treatments are more effective earlier lines in therapy, so clearly what we've always been thinking about is that we should use the best treatments earlier on. And so if we do so, how does that impact how we treat patients later on? And also what we do know is that access is a major problem. And so for some regions, you will be able to access maybe CAR T-cells earlier on, but other regions may not be able to access CAR T-cells earlier on and may have restricted access later on. So how does that come to play when you may have access maybe to a bispecific or an ADC at second relapse and your CAR T-cell therapy cannot be given until fourth relapse? We're going to try and tease all of this out in the discussion, so stay tuned for that.